but they are at risk of misdiagnosis, functional decline, and institutionalization. So, talking about healthy paranoia, this is an 85-year-old male with back pain. Can you see this? So something, a very powerful tool in emergency medicine, in my point of view, is ultrasound. What is the diagnosis? Yes, an easy one, but a thing to consider. So that's my first important statement. Please, if you have someone complaining about pain, identify the cause. Of course, that's well understood, and it's still important. So let's beware of these atypical presentations. Land sharks and snow sharks can be very, very dangerous. This is a restless patient complaining of abdominal pain. And the colleague treating care of this patient was also paranoid and rushed him to the CT scanner. And what's the diagnosis here? Yes. And he had excited delirium, hyperactive delirium. So there seems to be an association between delirium and pain also. And we've heard this, delirium is underdetected by us, and if we miss it, the next step of care will miss it as well. So in recent years, there has been a debate about overtreatment and undertreatment of emergency patients with certain pain medications, such as opioids. What do you think? Geriatric patients, are they overtreated or undertreated? Yes, undertreated. But the overtreatment seems to be an issue. This is a very, very recent article published a few weeks ago. In fact, it's an editorial saying, and this is United States only, if you prescribe 7,864 opioid treatments, you will create one heroin abuser. Okay? And so that would mean, as a 100% clinician, you will create one of these after 3 or 4 years. I think that's not at all true in our setting, and of course it's not true for older patients. And yes, they are undertreated, both receiving analgesics. You see this line here. These are big data from the States, and also receiving opioids. So the same thing, but not surprising. But what surprised me is this very, very recent study. So these are older people discharged, so they were cognitively intact, and they had minor injuries. But now, they had interference with their personal life. They developed chronic pain, their physical function decreased, it interfered with their general activity, and they couldn't enjoy their life anymore. So I think these are very, very important outcomes that we need to consider. So this is a great study underlying the importance of adequate pain treatment, even in minor injuries. So if we're swimming in the ocean, there seem to be very many different dangers. One danger, for example, I was swimming at, it's called Shark Beach in Venice, Florida, and suddenly this fin is coming up next to me. And I'm trying to move back to the land carefully, so this other fin is coming up next to me. And the other one is coming up, and I suddenly see these were dolphins just swimming next to me. So I was swimming with dolphins. So I mentioned, this is a quick summary of the first part, you are likely to develop chronic pain if undertreated. Mobility might be decreased and day-to-day function impaired, and also poor outcomes during hospitalizations. There have been many studies to show this. So what are the barriers to adequate pain treatment? Obviously, patient attitudes are important. Some patients don't admit that they have pain because they think pain, if I receive opioids, it's a sign of impending death. The providers are not well educated in assessing and recognizing pain and also treating it, and many more. There's actually a very nice review on this. I'm happy to send my EndNote library out to you. Also, it's recommended to have a regular pain assessment. Who's assessing pain in a standardized way in the emergency department? Some tool like NRS, VAS. Everybody or no? No, not really. Yes? Is it standard? Yeah, probably pretty much standard. Okay.
You have to say smiley faces.
Okay. Smile means yes. Okay. But I think personally, reassessment is key when assessing patients with pain. The American Geriatric Society recommends reassessing within an interval of 6 hours. I think that's ridiculous. I think that's really ridiculous. Okay, so reassessment is key and might be the problem. And we know, obviously you're all systematically assessing pain, and your patient's pain is more likely to be treated if their pain is systematically assessed. So these tools are very helpful, but often they are not recorded in older patients, and we've learned about the barriers. But by failure to assess pain, we are unable to treat their pain adequately. So there are different tools that can be used, and in this study, the verbal descriptor scale outperformed every other scale. No pain, mild pain, moderate, severe, extreme, most intense. It appears to be a little more sensitive than the other tools. We have not implemented this tool yet. I'm not sure whether it's so important. More important is to recognize patients in pain. And there are a lot of non-specific signs indicating pain. Mental status change, the gait, and depression, bracing, all non-specific signs that might be misinterpreted. So we need to look for these. So now, what about pain assessments in patients who are unable to communicate effectively? How do you do it? Do you use tools?
There is one.
There's one tool?
Pain assessment.
Pain assessment tool?
Yeah, tool for bodily, body language.
Okay,
From
yeah,
the patient.
that's right. Yeah, so there are 32 or 37 tools. Unfortunately, many of them are not validated for the emergency setting. There's one, and I do not have a conflict of interest towards this tool, but it's the only one, to my knowledge, that has been validated across different settings. So also for care transitions, it would be valuable. So we implemented this in our setting. So it takes 1 minute to assess the patient, observe the patient, and if you have 2 yes it will indicate that the patient is suffering from pain. Of course, I'm aware that describing pain only in terms of intensity is like describing music only in terms of its loudness. So we need to look, where does it hurt? What's the intensity? What's the quality? When did it start? Are there factors aggravating it? Are there factors alleviating it? Are there other associated symptoms? So it's very important to get the whole picture. By the way, who of you has these kind of things? One. And we just bought a few of those because patients don't like to be forced into these. How do you call them? Gurneys? Trolley? Trolley. So there was actually a small study about 10 years ago showing that patients who were on one of these had less pain and they were happier. So we bought these now. Okay, so what are our weapons against pain? Here, polypharmacy in our setting is very, very frequent. Look at this. This is a patient who I was supposed to. It was a crowded day, a crowded shift. 23 different medications, and I'm not counting Cerumen X. Cerumen? Okay. And the procedure was back to psychiatry. Okay. I just want to remind you that 3 groups of medications cause about half of all drug-related problems. Meds that affect coagulation, blood sugar, and the medications that have a narrow therapeutic window. There's going to be a workshop about medications later on. So I'm going to try to convince you not to use NSAIDs. We know that NSAIDs are Jesus, what's that word? Associated with gastrointestinal bleeding. What you might not know is that 1 in 5 are lower GI bleeds. But that's a very, very common side effect. But bleeding risk increases if you combine NSAIDs with other medications. And something you might not know is that it's associated, SSRI are associated with bleeding risk as well. So if you combine them, it might be dangerous. So here are the concrete numbers. So the most dangerous combination is with aspirin, but also warfarin and NSAIDs are very, very dangerous. This is a beautiful study with matched controls. Also, and you might have read it last year, patients with antithrombotic therapy after myocarditis, big study again, increased risk of bleeding, of course, but also, and that's interesting, increased risk of thromboembolic events. You might not have known that. So very, very dangerous. And a similar pattern, so that's why I believe it's true, has been shown in patients with atrial fibrillation receiving antithrombotic therapy. Also, increased risk of bleeding, but also increased risk of thromboembolic events. So important. And also, what surprised me in both of these studies, this was not associated with long-term NSAID use. This was not a function of time. Also, these events occurred after short usage. NSAIDs are leading to sodium retention. They are raising the blood pressure, and they will make your heart failure patients decompensate. Risk of decompensated heart failure is 26.3, increased by a factor of 26.3. If you have no heart disease, it's still increased. Also, they have an impact. This is River Rhine, close to Düsseldorf in Germany, a few years back. They are decreasing the GFR, and if you combine them with ACE inhibitors, they're going to be the reason for patients' acute kidney injury. This is an old study, but this is failure, so rifle failure, so severe kidney injury. So I hope I convinced you not to use NSAIDs. What about opioids? We know these common side effects: nausea, constipation, and this is almost 100%. So please never discharge a patient without a bowel regimen. Sedation, the patient is going to get used to sedation, and the always feared respiratory depression is pretty rare, 1.5%. So what's not well known is opioids are increasing the risk of falls and hip fractures. And there's going to be a whole workshop on hip fractures, but we have a good body of evidence that they increase also the risk of hip fractures. Also, they will increase your risk of developing delirium. So it's now difficult to determine what's the hen and what's the egg, delirium and pain, but they are closely associated. So the Beers criteria, you might have heard of them. They were created in a modified Delphi procedure, similar to our emergency curriculum for older patients. And the most recent from 2015, and I'm going to give you the three most important things: NSAIDs, chronic use. So I think it should be, this recommendation should be strengthened and said, forget about NSAIDs. And secondly, I don't know, meperidine was very, very popular in the settings that I worked. Is it popular here? Not at all, okay. And muscle relaxants due to their anticholinergic properties. Oops. So sadly, there are no evidence-based guidelines for pain therapy in older patients. This recommendation here is expert opinion, not mine, and based on the pain ladder of the World Health Organization. So in case of mild pain, you can use paracetamol. Is metamizole popular here? Not at all. I love it. I love it. And I'm happy to go into discussions with you about it. It's amazing. Oxycodone for moderate pain. Tramadol, I hate it, but I hear it's popular here. Is that correct? I hate it. I think it's a very strong emetic. And severe pain, morphine and hydromorphone. IV hydromorphone is good with reduced GFR. In any case, you will have to reduce your dose by 50% due to different pharmacokinetics in the older patient. And one last thing, and there's going to be a workshop about this, is the hip fracture. This was Marc Antonio's studies showing that almost half, I think it was 40-something% of the patients with hip fractures developed delirium, and the ones with delirium, they had a greater risk of ADL decline, ambulation decline, nursing home placement, and mortality. So what we start implementing, and I think you have nice guidelines already since 2014 in place with certain management protocols for hip fractures. We just start with regional anesthesia. Who of you does that? Okay, wow, that's great. That's great. Okay, so you're ahead of us. We just implemented this in our emergency department, and in fact, I love it. It's not that hard. Lastly, what do our patients want? This was a study of patients with fractures. They want early treatment. They want, and they're okay with nurse-administered medication, even before physician evaluation. It's absolutely fine. And thirdly, ideally, they want pain control without sedation. In summary, so assess pain type, comorbid status, medications, the risk of polypharmacy I mentioned. Avoid high-risk medications. Dose your medication according to hepatic and renal function, and choose the least invasive route. Start low, go slow. Everyone has heard that statement. And assess and reassess for therapeutic efficacy and possible adverse events. Be shark smart. I love the ABCs. We've learned that ATLS is out, but it's a very good way of communicating. A, B, C, D, E, F, G, don't ever forget glucose. I promise once I will make this statement in any talk I give, don't ever forget glucose. And I recently heard, always begin cautiously. Thank you.
For an excellent talk. I'm sure there's plenty of opinions in the audience in terms of the optimal pain management in older people. It's great to have a few examples up there to debate. So do we have any questions or comments from the floor? Oh, Professor Conroy.
Thank you, Christian, for an eloquent and evidence-based talk as ever. Your point about non-steroidals as long-term analgesics is well made, but the harms associated with them. But for acute pain, particularly musculoskeletal pain, trauma, in selected patients without acute kidney injury, without recent GI bleeds, are they not a reasonable option to consider?
Absolutely. I tried to make this polemic statement in order to get the message across. Absolutely. I use them in patients who have no impaired kidney function, who have known prior heart disease, who are not on an ACE inhibitor. And yes, in selected patients, you can use ibuprofen 3 times 200 milligrams, and you're probably going to be fine. Your risk of acute kidney injury, for example, starts after treatment for 5 days. Okay, so this seems to be a cutoff, right? So I have become, since these studies with the patients on anticoagulants, a little bit more careful, and I'm suggesting, if I use them, close monitoring with the primary care physician. So absolutely, yes, ibuprofen 3 times 200 milligrams, not the 400, are a reasonable option. By the way, what do you think? Which medication is more powerful, paracetamol or ibuprofen? Just shout. Okay.
Let's do a show of hands. Hands up. Who thinks paracetamol is more powerful?
Okay.
And hands up. Who thinks ibuprofen?
Who thinks ibuprofen is more powerful? Okay, that's the minority. It's the other way around. Paracetamol has a number needed to treat of 4 to reduce pain levels by 50%. Ibuprofen, however, has a number needed to treat of 2.2 or 2.4 to reduce pain by 50%. So it's more powerful. Okay? Yes, your point is well taken. More questions? More questions to shut me off?
Do you use any intranasal stuff? Because, I mean, as Tim already said, a lot of my practice is from children, so we use intranasal diamorphine in the children's ED, and have been using intranasal diamorphine for agitated old people with fractured femur before we go down going anywhere near the needle. And now we're going to start using some intranasal fentanyl. Have you any experience in this?
Not much experience, but yes, we use it. Who uses lidocaine patches? They're great. I've just discovered them. They're great. I've discovered them for my patients.
What do you use them for? What particular pain?
Post-herpetic pain is just a wonderful indication for that.
Do we have any other questions or comments from the floor? Oh, yes, one down here from the hand.
Apologies, I'm a pharmacist, but I've had plenty of experience with patients given one dose of non-steroidal, generally the IV or the PR, ED bullet, bit of Voltron, who then, because of a combination of factors, I'm not saying it's just the NSAID, but they're generally septic, hypersensitive as well, and they go into API, so I don't think it is just chronic use, and I think a lot of the meta-analysis that have been done has not related it to time of usage, in my experience.
But in specific indications, you can use it for stable patients with normal vital signs and all the exclusion criteria I mentioned before. I think you're fine to use it. But see, Simon, I have someone on my side. Okay, let's have these guys.
So the issue here for me is about opportunity cost. Yeah? So we've had a lovely summary of the evidence about why treating pain is important in terms of function, mobility, falls, delirium. Okay, so if we have so we can't give codeine, we can't give tramadol, we can't give opioids. We need to give something for musculoskeletal pain in the right patients. It's there is no. If you do nothing, you're going to cause harm. If you do something, you're going to cause harm. You've got to do something to try and improve the situation. So I think judge it on individual patients, but a short course for a few days, maybe with a bit of gut protection, is worth trying.
Problem. Everybody in here is an expert in pain medication, so it's going to be controversial anyways.
Well, it's just a very...
Oh, sorry, of course.
Yeah, just a very simple question. We're going to use 200 milligrams as opposed to 400 milligrams. Does it work at that dose in the elderly frail? Is it like...
Yes, the number needed to treat is only slightly lower with the lower dose. Yes.
Thank you.
Okay, I think we're going to have to wrap the questions on that session up there, but thank you very much, Dr. Nicol, for an excellent talk.